In ancient Greece, headaches were viewed as powerful afflictions that demanded direct intervention from Asclepius, the god of medicine. When prayer failed, medical practitioners turned to their most extreme remedy, drilling a small hole directly into the patient's skull to drain out supposedly infected blood. This technique, known as trepanation, often traded the patient's temporary pain for permanent neurological damage or death. Modern doctors have abandoned the power tools, yet the core of the problem persists. Despite our advancements, this ancient ailment continues to affect millions of people across every culture on Earth. Our difficulty in treating the condition stems from its dual nature. Science classifies headaches into two distinct categories: secondary cases, which we understand quite well, and primary cases, which remain largely unexplained. Secondary headaches make up 50% of reported cases and function as a biological alarm bell. They signal the presence of over 150 different underlying health problems. While the triggers range from simple dehydration to serious heart disease, we can map the physical pathway of this pain by looking at a common sinus infection. The sinuses are a network of cavities behind your forehead, nose, and cheeks. During an infection, your immune response heats up the area to kill bacteria, causing the sinus linings to inflame and expand. These engorged sinuses then mechanically press against the surrounding cranial arteries, veins, and neck muscles. That physical pressure triggers specialized pain receptors called nociceptors, which send a distress signal directly to the brain. The brain responds by releasing neuropeptides that cause cranial blood vessels to swell and pulse, creating the characteristic throbbing heat of a headache. In secondary cases, the pain is a clear mechanical reaction to a specific irritant, a direct line of cause and effect that doctors can identify and treat. The other half of cases are primary headaches. In these instances, there is no underlying injury or infection causing the alarm to go off. The headache itself is the disease. The most frequent type is the tension headache, known for creating the sensation of a tight band being squeezed around the skull. We can see the biological mystery of these headaches when we look at common triggers like dehydration. While dehydration causes the frontal lobe to shrink away from the skull, the resulting swelling doesn't actually match the location of the pain reported in tension headaches. Migraines are even more severe, manifesting as recurring attacks that can overload the brain with electrical energy for up to 3 days. This electrical surge hyperexcites sensory nerve endings, often producing visual hallucinations called auras, where patients see flashing lights or jagged geometric patterns. Cluster headaches are similarly intense, causing stabbing bursts of pain behind one eye that result in physical symptoms like pupil constriction and redness. Despite these distinct symptoms, we still don't know the true origin of primary headaches. They may be caused by spazzing blood vessels, overly sensitive nociceptors, or a biological process we have yet to identify. This divide between known and unknown causes determines exactly how we approach treatment. Because secondary headaches have clear triggers, they can be managed by avoiding eye strain and dehydration, or by using over-the-counter anti-inflammatories to reduce swelling. Primary headaches, like migraines and cluster headaches, are more difficult. Since the underlying cause is elusive, we haven't discovered a reliable treatment that works for every patient. Today, pharmacologists and neurologists are mapping neurological pathways and testing new compounds, trying to pinpoint the biological triggers behind these severe primary conditions. Ultimately, a headache is either a legible biological warning or a profound neurological misfire. Either way, it serves as a reminder that large portions of our own internal experience still remain outside the reach of modern medicine.